All right, so we're gonna go through this together. A 42-year-old woman with past medical history of asthma and recurrent nasal polyps presents to the emergency department with acute onset of wheezing. So she has asthma, recurrent nasal polyps, and wheezing. Chest tightness and nasal congestion 30 minutes after taking acetylsalicylic acid. What is that? Aspirin. For a headache. She has no underlying history of urticaria. What's that? What's that? Little bumps, urticaria, swelling or bumps, and angioedema, swelling of our nasal mucosa. So what is the following is the most underlying mechanism for her symptoms. Now, we read the question, and I want you to kind of think about how you attack board questions. I want you to get in the habit when you get a board question and when you're practicing for your exams, is I want you to read what are they looking for first? What are they asking? Because sometimes you're going to get these huge vignettes where these long sentences, and what do they really want? What is the purpose of this question this board is giving? So the first thing is that, so what is the mechanism for this lady's symptoms? So she's having asthma. She has a history of asthma and recurrent nasal polyps, but she's getting wheezing. So is she having an asthma exacerbation? She's having chest tightness and nasal congestion. So usually nasal congestion is something most people wouldn't say that they had as an asthma exacerbation. So what's our first choice would be IgG, mast cell degeneration. Or B is going to be direct histamine release from basophils. C is going to be inhibition of the COX-1 leading to increased leukotriene production. So we already talked about this patient is taking aspirin, right? And we already know it's a COX-1 inhibitor, so maybe that's something. In selection of COX-2 inhibition, so aspirin is not going to be selective to that. So there was medications that were very popular for a period of time that they were selective towards the COX-2. They were marketed as this, hey, these medications will cause less GI distress. Didn't work out as well. They did cause less GI distress, but they didn't take care of the COX-1. The COX-1 was the important part that we used to prevent heart attacks. And then serotonin release for the anterior chromatophorin cells. So none of that. So we need to start doing is when we're doing our board questions, we need to start getting the habit. So this is when you practice now is that we need to start eliminating things. So we probably know is this is not an IgE. We're not going to look at direct histamine. You know, select COX-2, those are a different medication. And then serotonin release is going to be something totally different than we'll talk about. So we kind of go and we break down what is going to be what our answer is. So what is our answer? So we're inhibiting the COX-1, leading to increased leukotriene production. And I'll show you why this is important, because if a patient takes aspirin, say somebody comes in for a heart attack and they take aspirin and then they have sudden wheezing, what are you going to do? How are you going to treat this? And what is this presentation? So now you may have a multiplier effect is that you have somebody coming in for a heart attack, you gave them a medication we said helps reduce heart attacks between 25 and 30%, which you're supposed to be, if this is the first medication you should give, and now we have wheezing, we have chest tightness and nasal congestion. So what are we looking at? So the patient took aspirin and started wheezing. So we have aspirin exacerbated respiratory disease. Now, you may not have heard about it, but this is a true thing. They like to test it on boards because it's one of those things is that you're giving it a life-saving medication and you're having a reaction to that life-saving medication. So Sapner's triad, and this is what we're looking at. So aspirin or NSAID sensitivity, we talked about the symptoms began within 30 minutes to 2 hours after you're taking aspirin. So 20% of the patients are asthmatics, okay? So we talked about this patient has asthma as a baseline. And they may have nasal polyps. So if they have chronic rhinosinusitis with nasal polyps, they have a higher preponderance of this. So what is the treatment? Well, first you want to avoid aspirin products. So what would be another product that we could use, say if they're having a heart attack? We'll talk about them more, but clopidogrel could be a product that we could use, okay? That is a medication that's going to stop the platelets from getting together. And then you need to consider if this patient is, and they need to avoid other NSAIDs too, because this is also going to cause the COX-1 inhibition, and we'll talk about the mechanism of this. And then they can use this leukotriene receptor antagonist, montelukast. Now, you've may seen and given patients montelukast in your careers. And what's the side effect of this medication? It's very important because The side effect, it used to be very popular medication and it went away because the problems it caused was depression, suicidal thoughts, and hallucinations. So that's something you really want to avoid, and there's people that have harmed themselves from this. Now there's also another type of salicylates you probably haven't heard much, it's called sodium salicylates. And you can use those, but you want to avoid your aspirin products and your NSAID products. So, and then for the nasal polyps that these patients can have, the treatment is for surgery, and it's usually ENTs the ones that would be involved in that. So let's look at the mechanism, okay? And this is kind of going to help you understand drugs. I implore you to learn the mechanism of drugs. I know that when you're doing pharmacology, you kind of just want to get through it and you want to memorize it, and it becomes like this gross, horrible memorization event where you're trying to memorize things, so many things, but we need to go back and understand the mechanism, because when we're given this drug and something happens, we need to know is what part and what system is being hit. So we have right here is we first has our membrane phospholipids, okay? And our membrane phospholipids, so we have right here, they get broken down, okay? Now, what can stop the breakdown is right here is corticosteroids. You see this right here is corticosteroids can stop the breakdown. So that's why, so the breakdown of these phospholipids, what does that cause? It's a release of androgenic acid. And it causes excessive mucotriene production. So when we have a breakdown of our membrane phospholipids, we come down here and we can get these breakdowns of these two products, okay? And on these two products right here is the adrenergic acid can cause what? It causes muscle aches. So when you have the breakdown of your cell membranes and your cell membrane phospholipids, you can cause muscle aches and pain, okay? And because you're getting these products, these prostaglandins, and they cause pain. So when you think about pain, you think of prostaglandins, okay? And it causes this pain. So when you give corticosteroids, just think about, have you ever had muscle aches and somebody's prescribed them corticosteroids? You're stopping the breakdown of this membrane phospholipids. So you can't form the prostaglandins. If you don't form the prostaglandins, what happens is you don't have the pain. So those prostaglandins give a pro-inflammatory mediator and increase the excitability of the peripheral nerves, and it's sending pain signals back to our brain. So when you have the breakdown of this product, our membrane phospholipids, so if you have, say you sprain your ankle, you're going to have a breakdown of those membrane phospholipids. So then we have formed this adrenic acid. So where do the COX-1 and COX-2 inhibitors come from? It's right here, and this aspirin right here. So what happens is you have the breakdown, and they block the breakdown of prostaglandins, but they can cause what? In certain patients, it can cause the leukotrienes to be more. And this is where you have the vasoconstriction, the bronchospasm. And this is what that patient is experiencing. So this will help you understand is it rare? Yes, but it can happen. In these patients, you need to be able to take care of them. Boards likes it because aspirin is commonly given. A lot of people take aspirin. And if they take the aspirin, the life-saving aspirin that you give them, and you cause harm, you need to know what you can do to fix this. Now let's talk about clopidogrel. It's another, it's a P2Y platelet inhibitor, okay? P2Y inhibitor. Same thing, what it does is stops the platelets from aggregating. Now it's a prodrug. Now this can be important, is it's a prodrug, so it gets broken down in our liver, and it takes 2 steps, so it takes time for it to work. So what do they do for clopidogrel? They give high doses. If you give high doses, what it does is it acts faster. So some places will do is they'll give 300 or 600. If you give a high dose of it, it makes it work faster. In 600, it can be active in like 5 minutes. Now, some ethnic groups have a higher incidence of not responding to the drug. Now, there is testing for this, and it can be some ethnic groups, it's usually Southeast Asians. And some of these ethnic groups, they do not respond to this drug. So what happens is they're taking this medication and they're not getting the value for this. Now, there is a test that can be done, but there's not great evidence that says that we should do this for certain groups. Maybe someday, as it gets cheaper, we can use this more to make sure other groups get taken care of and that we're giving the right medication for the right person. I imagine someday in the hospitals we'll have, or even in your clinics, you have a little machine and you basically get a little drop of blood, and from there we're going to know right away what works for different people. Now remember, there is no reversible agent. So what do we use clopidogrel for? It's used for all sorts of things. We talked about it for acute coronary syndrome, which is MIs and can be used for recent strokes or peripheral artery disease. Because remember, in a peripheral artery disease is that we're having what? Is the platelets are aggregating and we're stopping the blood flow to our legs, just like we're stopping the blood flow to our heart. Now, the recommended initial dose for ACS is going to be 300, and it's a loading dose. Some places you'll see will use 600 because it goes faster. That's going to depend on what your team has decided. Then your following dose is going to be 75 milligrams daily. And this initially will be usually given with aspirin, and we'll kind of talk about this in what the dual platelet therapy, what we're talking about. We'll talk about that in a little bit later in the lecture. Now, for recent MI or stroke, established peripheral artery disease, usually you're going to continue that 75 milligrams daily. Now, remember we talked about it is that it's a prodrug, and that prodrug is broken down by the CYP12 system in our liver, and it's an active metabolite. And what happens is, remember, certain patients are going to break that down, so we're giving them medication that they can't use. So what can we give to those patients? Prasugrel. So this is a medication, this came out with a lot of hope that this was going to be the medication. Clopidogrel was doing well, but this prasugrel is not a prodrug, it's an active drug. And it's a P2Y12 inhibitor. It's a prodrug. This has predictable hepatic metabolism. So there's no reversible agent in this too. Now, the side effects in this is that it's contraindicated in older patients, okay? So this is greater than 75 years old. They can have more significant bleeding than they can with clopidogrel or aspirin, and it can be life-threatening bleeding. And you want to avoid in history, so remember we were giving clopidogrel to people who had strokes and they had TIAs. You want to avoid in these patients that have a history of TIA, strokes, and hepatic dysfunction. So it kind of limits a lot of our patients. So anybody over the age of 75, we can't give this to. And if they had a TIA or stroke, we can't really give this to them. And if they have any hepatic problems, we really can't give it to. So this drug came out with a lot of, we thought this was going to be the answer, and it really didn't work as well as we wanted to and had a lot of side effects. Now, I want you to think about too is you're going to see some of these other side effects with clopidogrel. There's going to be a percentage of patients, it's roughly about 4% of the patients will have bradycardia in the first couple of days, and after a month, the bradycardia kind of goes away. So we don't really think about clopidogrel as having a side effect as bradycardia. And I imagine a lot of you have seen or given this to patients, and a side effect can be bradycardia. Now, prasugrel and ticagrelor, and we'll talk about that one later, they have a higher risk of bradycardia. They can have about 6%, and during the first couple of days. All these medications, as they get taken for longer periods of time, the risk of bradycardia is less. So what causes this? It inhibits the adenosine reuptake, causing bradycardia and dyspnea. So adenosine, I'm sure that you guys have used adenosine or seen adenosine, so it can do this. Now, prasugrel is a prodrug that is rapidly hydrolyzed by the intestinal enzymes and is converted by the hepatic cytochrome P450 enzymes. So this is where patients who have hepatic dysfunction can't use this medication. And here again, as it binds to the platelets, it's a just like we talked before, it's a P2Y12 inhibitor. And it stops the clotting of the platelets, stops the platelets from getting together. So that way we have open blood flow to all of our areas of our body. Now, it's usually a loading dose and it starts working significantly within 20 to 30 minutes. Now, ticagrelor, this is another medication. And this one is becoming more of what the cardiologist's best friend is. Now, the problem with this medication is right here, the twice-a-day dosing. We just remember is that the more medications and the more times the patient has to take medications during a day, the less likely they're going to use it, or they'll forget to use it. And this is a twice-a-day dosing. Here again, this is a P2Y12 inhibitor. It's an active drug. So this one, we take it and it works. We don't have to worry about where it's getting broken down and if someone is not going to have the ability to break this medication down. There is a monoclonal antibody that can reverse it. And you want to avoid this patients with history of intracranial hemorrhage because they increase risk of bleed. Now, the big side effect of this is dyspnea, shortness of breath. All right, so you wouldn't think about this. This is a medication to stop clotting, but the side effect of it is it can cause shortness of breath. And it can be pretty profound in some patients, about 15 to 20% of the patients. It's usually self-limiting, but 5 to 7% of the patients, they have to quit because it just becomes too much. Now, the typical loading dose is going to be 180 milligrams, and it's followed by 90 milligrams twice daily. And it can be a lifelong drug. And we'll kind of talk about this, which medications we're going to continue or not. Now, we're going to use the term cost. Remember, aspirin is going to be dirt cheap. Clopidogrel is pretty cheap, and it's on the lower price in most of the big box pharmacies and the big box stores. It's usually on the reduced price. Ticagrelor is not, and Prasugrel is not. So they can be expensive and can be a burden to our patients for these costs. And this is where we're talking about mono versus dual therapy versus triple therapy. So mono versus dual versus triple therapy. And we'll talk about this because this is going to be important. There's a lot of literature on this is changing, and this is what you're going to be prescribing to your patients after they had the heart attack. This is what you're going to be managing. You're managing it in the hospital, and you're managing an outpatient. These are what you're going to be managing. So monotherapy use of a single agent is either going to be aspirin or P2Y inhibitor or anticoagulation alone. In anticoagulation, what are we talking about? We already talked about what aspirin is. We know what that is, acetylsalicylic acid. We know about the P2Y12 inhibitors. We have the main ones are clopidogrel. We have ticagrelor and prasugrel. Those are our P2Y inhibitors. And then anticoagulation, what do we think about that? Well, mainly it's going to be what? Our DOACs, and we'll talk about those, and our Coumadin. Now, dual therapy is going to be ASA or P2Y inhibitor or anticoagulation. So we're just taking two of these, okay? And then triple therapy is aspirin plus P2Y12 inhibitor plus anticoagulation. Now, you don't see much of this, and we'll talk about when this is used. Now, you don't see much because it can have a high risk of bleeding. So this is used for 1 week to 1 month after a PCI in a patient who has atrial fibrillation. So they have atrial fibrillation, plus they've had stents placed. Then it needs to scale back to dual therapy. And this can be a challenge is when do we do this? And it's probably going to be the P2Y12 inhibitor plus anticoagulation, and that's going to be 6 to 12 months. Then back to the oral anticoagulation as monotherapy. So this patient has come in, they've had the heart attack that we discussed, they've gone through the cardiac cath, they've had a stent placed in that stent, and they also have atrial fibrillation. Now, they may have had the atrial fibrillation prior to having the MI, but just think about it. If our heart is not perfusing well, we have an increased risk for cardiac arrhythmias. And now this patient has atrial fibrillation, and they just had stents placed. And so that we would require anticoagulation for the atrial fibrillation, but also we need to give those medications. So what happens if we don't take medications after our stent place? What you run the risk of is what? In-stent thrombosis, meaning a clot, they put that stent in there, and there's medications on those stents to stop it from clotting, but those clots in there can form, and then basically you have to go back and reopen those stents up. So you put the stent in, remember it's opened with an angioplasty, so you put the stent in the artery that has stenosis, and you open it up. And when you do that is you need to take these medications. It's usually going to be dual therapy with aspirin and P2Y inhibitor, so to stop clots from going in that stent. So anytime you have a foreign object in your body, I want you to think that there's an increased risk for clotting. It's not a natural part of your body. There's something in there. What happens is the body kind of fights it, and you're going to have something form in that surface, and you have increased risk for clotting. Now, they do a lot of great work where they try to avoid having the body's response to this, but it's still not perfect. So you have to get something in there to keep those vessels open. And if you don't keep those vessels open, you have a clot. And then you need to have the anticoagulation for the patient who has atrial fibrillation. We'll discuss more about that. Now, if a patient has a cabbage, and this is a discussion, what your dosing is going to be in your system, you take aspirin, okay? And this is to reduce vein graft closure. This is still the standard of care. Remember, this was found over 3,000 years ago, and this is the standard of care that we give to people who have a cabbage, to keep those arteries open, to avoid those grafts that they've done, those vein grafts that they've taken out of your mammary artery or your saphenous vein. And when they put those into your heart, they need to keep those open.